Well, first of all, thank you to the conference organizers and for inviting us to this panel and to get things started this morning. We're very privileged to be here. My name is Attila Herdelendi. I'm a professor at Florida International University in the College of Business. I do research in AI implementation. Also, I wear another hat at Harvard University, where I am the Director of Research in the Disaster Medicine Fellowship at BIDMC. And so I also wear another research hat over there. And so this makes it very realistic in terms of what we're going to talk about, because I'm going to give you the practitioner plus the research perspective and what I'm seeing in terms of healthcare organizations globally and around the world. We have no disclosures, so we'll just zip over there. One of the things I want to start off with is give you just a big macro picture in terms of what have we learned since the pandemic. And when we look at the literature and when we look at current practice, we find that there's a lot of gaps in terms of pandemic preparedness. And we just see that right now. In fact, we have a paper under consideration at a top journal, I won't say which one, talking about the hantavirus response and the clear misses there. And it gives us an opportunity to pause in terms of what we need to be thinking about in the future. We have a lot of disasters that are happening all around the world, particularly if we look at data from last year. Even in the United States, doesn't matter where you look at, everyone's impacted in some way, shape, or form. And you're wondering, how does this impact it, and what does this mean in terms of healthcare? How many hospital executives are here right now? Put up your hands. Great, I'm talking to you now. So when you're thinking about this and you're looking at long-term planning, one of the things that's impacting you right now, obviously, is AI. Everybody is impacted by AI. Hopefully you're ahead of the curve. If you're not, let's have a conversation at the break. But the other thing that's people are impacted, doesn't matter where you are, is disasters. They're increasing in duration, in frequency, and really geographic footprint. In fact, if you looked at what we have coming up shortly, we have a El Nino event that people are just starting to talk about. One of the things that I looked at as a researcher as well is how are we preparing future healthcare executives? And we found during the pandemic, in this paper that we published, that we didn't do a really good job preparing people. In fact, the only course that is taught by my colleagues, actually in the School of Public Health by Dr. Friedman, that's the only program in the country at the time that was offering a disaster medicine training course in their Masters of Public Health in the nation. And we wondering why healthcare executives were so challenged with responding to disasters. We argued that this should be taught actually as a core competency. In the latest journal of the American College of Healthcare Executives, the Journal of Healthcare Management, we actually wrote a paper that looked at how healthcare executives felt during disasters and how they felt during preparedness, and they were very candid in their reflection in terms of what they need to focus on. Here are some of the areas that they need to focus on. This is the big macro picture I really wanted to leave you with. You can't be thinking only about one exercise at a time or one event at a time. So recently I did a tabletop at a large healthcare organization that I led, and this is the major gap. They were only thinking unidimensional. In fact, the other thing that they weren't thinking about is that this wasn't serious. They didn't even activate hikes, which is very interesting. Like, how are we going to build that capacity if we're not really simulating these disasters? And more importantly, how are we simulating two things happening at the same time? A longer term downtime event, for example, not just a couple hours in the tabletop. What about if you had an active shooter event happening at the same time? Or where I'm at in Florida, we have to think about this quite frequently, and that is hurricanes and some other threat happening at the same time. So the big picture is that more and more evidence is accumulating that we are really not adequately prepared. Think about what happened. This was an example of Heathrow Airport last year that was taken down by a structural fire beside it. How does that exactly happen? How does that headline that just came out a couple of days, those of you that have any academic affiliations, you saw that Canvas, which was our main LMS, was down. Okay, that should be a harbinger. In fact, I posted on that on LinkedIn. It's like, hey, this is a wake-up call We need to be thinking about that in terms of what happens if Epic failed. What happens if you had a long-term outage in that area? How are we prepared? How are we thinking? So this first session that I just did right now, really hopefully got you thinking about, hey, this is real, this is an issue, and again, I've written about this now for years. We are absolutely not, as a nation, prepared, and my colleague will back me up on this, for the next event. And when I next event, I mean is the big one, a pandemic or some other novel virus. Hantavirus, you see all the headlines, people are going bananas. That's not going to be COVID, okay? We're not going to have a pandemic out of the hantavirus, but it's a wake-up call to start thinking about multiple events happening at the same time, and also the implications of AI on your organizations. What happens if your systems fail? How are you prepared for a longer-term event? All right, and with that, I'll just leave you with my contact information, and I'm going to turn over to my colleague. Thank you.
Good morning. My name is Natalie Sullivan. I'm an emergency medicine physician, and I completed a fellowship in disaster and operational medicine. That is my subspecialty of interest. Today, I'm going to be talking to you about the clinical impact of cybersecurity and attacks on our system. So I want to make this more personal. I want you to imagine you're in our emergency department. It's 2 a.m. You've been waiting. You're with a loved one. You're seeking care. And you find out that our computer systems are down. Does that give you a sense of confidence in the care you're about to receive? It shouldn't. I think you should be concerned. If you've had any interaction with the healthcare system, which I know you all do, the delivery of modern healthcare is heavily dependent on the medical Internet of Things. So we know that we need electronic diagnostic testing, including radiology, lab systems, even handheld devices in order to make our diagnoses. We know that we utilize the electronic medical record not only to document our own findings, but also to leverage historical information so that we can provide better care. And we use medical devices in order to administer care to our patients. All of these things are dependent on the internet, on electronic devices. And although historically there's been a lot of focus around the risk of patient information exposure, I would argue that the cascading clinical risks of cyber attacks are much more pertinent to ourselves, our loved ones, and our healthcare systems. And so thinking about that, imagine it's not easy to deliver the kind of care that we're trying to deliver if our systems are down, there are significant delays. A lot of the metrics that you are judged on as healthcare organizations are time dependent, right? We have 90 minutes from the diagnosis of a heart attack to get someone to the cath lab. We have 4 hours from the onset of a stroke to get you the medication that you need in order to treat the stroke. And we have 3 hours, I'm sure the sepsis bundle is very familiar to all your healthcare executives, to get patients the antibiotics they need. It's very difficult to study this because of the potential litigation surrounding sharing this kind of information, but we do have studies that show that among patients that are already admitted to a hospital during a ransom attack, there is a 36 to 41% increase in mortality. And beyond a single hospital or hospital systems, we see that there are a plethora of regional consequences. So when one hospital goes down for whatever reason in disaster, there has to be some other way for patients to seek care, right? And so that hospital might go on diversion, EMS might reroute. There's cascading burden onto the surrounding hospitals. And so we've demonstrated that in an area that is affected by a cyber attack, not only is that hospital affected, but the outcomes in cardiac arrest in the surrounding hospitals are poor. As we're taking that regional lens, we also want to think about the critical infrastructure that hospitals are dependent upon. If you've seen the news in the last 5 to 10 years, there are obvious threats to utilities from cyber attacks, right? We know that our hospitals are incredibly dependent on water, on electricity. If we lose water, we're not able to perform dialysis. We can't control the temperature in the hospital. We can't sanitize our equipment. Even though that most hospitals have some capacity for generated electricity, if there's a massive infrastructure attack, we're going to be competing with everyone else for fuel. So it's just a matter of time until that generator capacity is out. And when we lose electricity, we lose our vents, we lose our balloon pumps, we lose a lot of our diagnostic equipment. So you can only imagine that there are massive opportunities for exposure. And so now that we've established that this is a threat and this is a very scary thing, what can we do about it? And so disaster medicine is a really nebulous term, and what we're really talking about is emergency management. Emergency management is rooted in systems engineering, and the idea is what approach can we take in order to mitigate, prepare, respond, and recover from disasters. So I want to take you through this framework and talk about what are some interventions that we can do now in order to prevent these outcomes. So mitigation is essentially what can we do so that when something inevitably happens, we can lessen the blow. And so that includes, technical advancement, training your staff, the usual don't click on the phishing attack, change your password, dual factor authentication. We can create physical barriers that make it more difficult for our systems to be penetrated. This, however, the preparation piece, I think is, where our most focus should be. So we did a study of hazard vulnerability analyses amongst emergency managers, and cyber attack wasn't even in the top 3 hazards for most of the hospitals that we surveyed. And to Attila's point, when we're thinking about vulnerability and hazards, we have to think about that polycrisis aspect, right? I was working in a hospital that was under cyber attack. We had no systems for 3 weeks in the middle of the COVID pandemic pre-vaccine. So think about that. We're already kind of in our total crisis situation, and now we're using paper. I'm embarrassed to say I'd never written a paper prescription before because I was very young and why would I? And so we have to create a system where we're addressing not only cyber, but all these other polycrises that could potentially happen at the same time. Our EOP is your emergency operations plan, so we're integrating this into our EOPs. We have robust plans for we lose our utilities, so how are we going to continue to generate electricity? What can we do? Could we potentially have a reservoir? Can we have a supply of bottled water to mitigate some of that potential threat of water loss? And then what kind of mutual aid agreements can we set in place? Is there an opportunity for something like a cyber response team? Some of our colleagues at UCSD are developing a system where they can actually bring in what they're calling a crash cart, which is a totally internalized internet, 5G, electronic medical record that is distinct from the existing system and cannot be exposed, but creates a parallel workflow that our practitioners are familiar with, and that kind of can continue the standard of care. Do you have a downtime plan, and have you actually exercised and planned it? We learned, our original downtime plan contained fax. No one uses fax. This is a completely inefficient way to communicate. And we found that human runners were the best option, right? So are you actually practicing what you preach? And then finally, what's your plan for the response during a actual downtime? How are you going to keep patients safe? How are you going to share information? Do you have a backup communications plan? What is your plan to contain the attack? And of course, one of the most important things to healthcare delivery is continuity, right? If you can't recover from a disaster, then what is the future of your organization? So how are you going to relaunch your systems? How are you going to integrate that manual information that you collected during downtime back into a digital format? And how are you going to evaluate, share, and debrief the lessons that you learned? So thank you for your time today, and we'll pass it on to Dr. Sainz.
The rose between 2 thorns. I'm the big thorn in your side. We're going to talk about cyber now, so strap in. Talk about the cyber threat surface, which is expanding, right? Let's face it, we are addicted to technology. Everything in our hospital systems now is connected. Everything is electronic. And the old days of doctors making decisions by licking their fingers and trying to figure out the wind direction is long gone, right? Many of you who are as old as I am will remember diagnosis in your doctor's office that seemed to be pulled out of thin air. It was based upon experience. It was based upon training. Now we're backing those decisions with large AI-based systems around clinical decision support and technologies that help us to diagnose patients much more effectively and also to treat patients, right? When you take those diagnostic systems away from doctors, they find it very hard to make decisions. Many are very uncomfortable making decisions without that technology because of the liability, the risks, and obviously practice concerns, malpractice insurance, all the rest of it, right? There's a whole heap of things that go into those decisions. I recently did an assessment of a healthcare system that had just spent millions of dollars on a business continuity plan and was brought in to test their systems and their resiliency. They failed in every single location apart from one location, which was a clinic up in Alaska that had a point-to-point wireless connection back to the mainland to its EMR. And when the winds blew, which was more or less every day in Alaska, right, these systems would go down. They were absolutely perfect. They scored 100% downtime procedures because everyone in that office, doctors and nurses alike, could revert to paper and revert that paper data back to the EMR when they got connectivity. We don't practice to that level in our hospital systems today, and if we do a DR exercises, what normally happens is that nurses don't bother charting patients. They tend to remember things or write it down on the back of a napkin and wait for the EMR to come back up. If that EMR doesn't come back up for 4 weeks, you lose that data. No one's going to have it. We are also dependent on third parties. Right? If you were to assemble the number of third parties in your healthcare systems that you rely upon today, it would fill a room, right? It's hundreds and hundreds. It's many more than most people realize. We've done assessments in various hospital systems and found that the number of vendors is off by an order of magnitude, right? And this is legal contracts, and security obviously is not always involved in some of those vendor decisions or conducting due diligence around those technologies. We are continuing to add AI systems at a prolific rate across our healthcare system. That is helping to drive efficiency, it's helping to drive patient outcomes, and it is plainly the future of medicine, but it's another single point of failure when our technologies go down. Perpetrators know this, right? One small attack by man, one giant disruption for mankind, right? They know that they can take out a critical vendor and bring down hundreds of healthcare systems. And we saw that last year or 2 years ago with Change Healthcare, right? A third of US healthcare systems were fairly significantly impacted. 192 million patient records were disclosed through that single attack. It's not just in the US, it's also in the UK. A single attack against a pathology provider, Synovis, killed one patient and increased or physically damaged another 25 or 26 patients as a result of delays in pathology services, took out 2 of London's largest health hospital trusts with one single attack against one single vendor. We are entering a period of technical debt, and we have been for quite some time. And by that, I mean our adoption of technologies is outpacing our ability to secure those technologies. We have a gap growing between digital maturity and cybersecurity maturity. We are playing catch up on the technologies that we are treating patients with that may not be secure because we haven't had the budget, the money, the resources, the time to secure those systems. We are entering high-risk zones, right? And with escalations in geopolitical tensions, those risks are now going through the ceiling. CNIs, critical national infrastructure industries, are in the crosshairs by nation-state perpetrators. We've seen attacks against electrical systems, against healthcare systems, against water management systems, even the postal system, right? Last year, the French postal system, La Poste, was taken down by a cyber attack. The year before, the Royal Mail was attacked following the UK's agreement to provide extra funding to Ukraine. I wonder who was behind that, right? Drawing any conclusions. The 2 events were 2 weeks apart, so draw your own conclusions, as I say there, right? It's not just postal systems. The Norwegian dam system was attacked in a cyber attack. Fortunately, no damage occurred. We've had dams attacked in the US as well, going back decades, and other critical infrastructure assets. At one point, much of the US electrical grid was owned by the Iranians, right? So, these are risks, they're escalating, and all it's going to take is a decision or for someone to upset someone else, and a lot of these infiltrations, these footholds could be activated. If our power goes down, sure, we have backup generators in our hospitals, but how long would it take for gas to get there when the roads are all shut down because there's no traffic lights, there's no air traffic control to fly in critical materials and everything else, right? So we got to think of the big picture, and this has a massive impact upon disaster medicine. More recently, the Polish rail operator was attacked, sabotaged both electronically and physically, right? Just this week, in fact, there was an attack against the rail system of Taiwan. It's in the press a couple of days ago. A 23-year-old student broke into the system because there was no cybersecurity in place to rotate encryption keys, and was able to cause an emergency alert to go out, which shut down the entire rail system, right? One simple attack. A report came out in The Guardian a couple of days ago talking about how Russia is investing heavily in the training of students for offensive cyber capabilities, right? This is state-funded cyber terrorism, essentially, against adversaries. The PRC, the People's Republic of China, has well over 100,000 offensive cyber staff, right? Now, just to put that in perspective, the entire staff of the FBI down the road is just under 30,000. That includes janitors, receptionists, everyone else, right? They have about between 10 and 15,000 investigators who are working to defend the United States against these sorts of attacks. We are outgunned, outmanned, and outmaneuvered, right? Who in the audience here has heard of Mythos? Raise your hand if you've heard of Mythos, right? If you haven't, you want to attend the cybersecurity panel later this morning that I'm going to be running. We're going to be talking about that. This is a game changer for everything that you thought was secure, because it isn't secure anymore. We're using AI offensively in order to discover vulnerabilities in systems, and that is really, really going to change the game. The odds are against us, right? We're outgunned, outmaneuvered, and the concept of a secure hospital is a pipe dream at this stage, right? We are not investing in cybersecurity anywhere where we need to be, and we need to start to think differently about resiliency and cyber preparedness. Doing more of the same is simply not working, right? Rearranging the deck chairs is not going to stop the Titanic from sinking, right? And this is what we face from a disaster perspective. We need to invest heavily in resiliency. It needs to be a priority. We need to plan for the unexpected, right? As Monty Python said, no one expects the Spanish Inquisition, right? And there's a lot of truth behind that, right? We've got to think outside of the box instead of saying, hey, this is the way we've always done these. This is the way that we've always made our business continuity plans, our disaster preparation plans, our cybersecurity incident response plans, our backup and restoration plans. We need to start thinking about, N+3 architectures, to put it in technical terms, right? What do you do when your backup systems go down? Where's your second backup, your third backup, right? How do we revert to paper? How do we train our doctors and nurses to revert to paper effectively and efficiently when all of our electronic systems go down? Do we have basic components like notepads and pens? Or do we need to send someone out to Staples to empty their shelves, right, the minute that we realize we're in deep trouble? And does that person need to be able to drive, at 100 miles an hour to get there before everyone else does, right? Because there's going to be a mass scramble for these sorts of things. We discovered during the pandemic that our just-in-time ordering system for medical supplies wasn't in fact just in time, right? It was just out of time, because the supplies of PPE and even basic syringes, was essentially run down very, very quickly here, right? And it resulted in nurses and medical staff having to wear a mask for a week in some cases. I know a lot of my colleagues in the medical space complained about that, but there was no alternative, right? We need to plan for the worst, and we need to practice. I once had a conversation with the CEO of a hospital system and told them that they need to actually practice their business continuity plans. They weren't doing so at the time. And the CEO said, but that would cost money. I said, well, what's it going to cost you if you don't practice and you go down? I said, it's going to mean that probably the closure of your hospital, right? And you're going on TV to apologize to the community why the hospital is closed because you didn't invest in preparation for disasters, right? We're on the crossroads, on the cusp of some major changes, and I think we need to think differently in order to survive it. With that, thank you very much.